Welcome. We're here to break down some absolutely critical concepts for your upcoming nursing exam today, focusing on cellular regulation.
We've gone through your study materials, really distilled them down to help you prepare efficiently.
Let's get right into it. Our first topic is cirrhosis. This involves pretty significant liver dysfunction. For your exam, we really need to zero in on its signs and symptoms, essential medication education, key diagnostic labs, and crucially, the priority interventions.
Yeah. And what's really key here, I think, is grasping how deeply liver dysfunction impacts so many other body systems. It's like a cascade effect, you know? Understanding those connections is really paramount.
Absolutely. So when we talk signs and symptoms, you need to be sharp on the symptomatic differences between early and late stage. That's a big one. One of the most common findings, and quite streaking with significant liver dysfunction, is third spacing and edema, especially ascites.
Right. And that's not just like general swelling.
No, exactly. It's specific abdominal edema. It happens because the liver, when it's damaged, it struggles to produce proteins like albumin.
Which normally keep fluid in the bloodstream.
Precisely. So when these proteins leak out into the peritoneal cavity, they actually draw even more fluid out with them. And that's what leads to that increased abdominal girth and often very rapid weight gain.
Exactly. And you'll see this protein loss reflected in the labs too, right? As decreased serum protein and decreased serum albumin. And beyond protein, the liver's incredibly busy metabolically. So when it's damaged, you see those elevated ALT, AST, and GGT.
Yeah, those liver enzymes basically spill out of the injured cells. It's a direct marker of damage. And a major indicator of how well the liver is handling waste is elevated bilirubin. Bilirubin, which is a byproduct of red blood cell breakdown, normally gets processed and excreted by the liver. When it can't, it backs up.
Leading to those telltale signs.
Right. You get clay-colored feces because the bilirubin isn't making it into the stool to give it its normal color. And you get tea-colored urine as the kidneys try to compensate and excrete the excess bilirubin.
And of course, the classic jaundice, that yellowing of the skin and eyes. Can't miss that one.
Definitely not. Now, beyond waste, the liver is absolutely essential for blood coagulation.
Which means a really significant and frankly dangerous finding is a decrease in clotting factors.
The liver synthesizes many of these factors, and it uses vitamin K specifically to make prothrombin. So when this whole process is impaired,
You get an increased risk of bleeding, massively increased.
yeah, you'll see patients bruising really easily, maybe complaining about that. But you must watch for the severe signs. Hematemesis, that's vomiting blood.
Scary stuff. And melena.
Right, those black, tarry stools that signal an upper GI bleed. And also hematuria, which is bright red blood coming from the rectum, lower bleed.
Okay. And what about electrolytes?
Well, you often see imbalances like increased sodium and decreased potassium. But for your exam, a huge red flag has got to be increased ammonia.
Ah, the neurotoxin.
Exactly. Ammonia is toxic to the brain. When the liver can't convert it to urea for excretion by the kidneys, it builds up. And that directly impacts the brain, leading to encephalopathy. You'll see this clinically as confusion, maybe agitation, even aggression.
And this high ammonia is often made worse by portal hypertension, isn't it?
Absolutely. Portal hypertension is a significant increase in blood pressure within that portal vein system.
Caused by the backup, right?
Yeah.
Blood can't flow easily through the scarred, damaged liver.
Correct. So the blood tries to find alternative routes, these collateral circulations. This whole process leads to a buildup of toxins, especially ammonia.
And a really dangerous consequence of that pressure is esophageal varices.
Yes, those are enlarged, extremely fragile veins in the esophagus. They're diagnosed with an endoscopy.
And they pose a massive bleeding risk.
Huge, huge risk. Portal hypertension can also cause splenomegaly, an enlarged spleen, because of that increased pressure backing up into the splenic vein.
Okay, so lots of systemic effects. What else might we see?
Patients might complain of pruritus, which is just intense itching. That's due to the buildup of bile salts under the skin. You might also notice distinct physical signs like spider angiomas, tiny red, sort of spider-like blood vessels on the skin, and palmar erythema, which is a reddening of the palms.
And that distinctive breath odor.
Ah, yes, the sweet, musty odor to their breath, sometimes called fetor hepaticus. It's quite characteristic.
And we shouldn't forget breathing difficulties.
No, definitely not. Because of all that pressure from ascites pushing up on the diaphragm, respiratory distress presenting as dyspnea, shortness of breath, maybe hyperventilation can be a really serious concern.
Okay, that covers a lot of the signs and symptoms. Let's pivot to medication education. The key here is connecting the drug to the specific problem it's treating.
Right. So for that dangerous increased ammonia, the go-to is lactulose.
How does that work exactly?
Well, basically, it draws ammonia from the blood into the GI tract. Then it promotes bowel movements, ideally aiming for 3 to 5 per day to excrete that ammonia out of the body.
Makes sense. Get it out. What if the cirrhosis is from alcohol?
Good point. If it's caused by alcoholism, you'll likely use benzodiazepines like oxazepam or lorazepam to safely manage the alcohol withdrawal symptoms.
And patients might ask about herbal things.
They might. Milk thistle is one you sometimes hear about, an herbal supplement thought to help with liver regeneration, though, the clinical evidence is often debated.
Okay. And for the fluid shifts, the ascites.
Right. For those significant fluid shifts, spironolactone is common. It's a potassium-sparing diuretic.
Ah, potassium sparing. That's important.
Very important teaching point. You have to caution patients about using salt substitutes. Many of them contain potassium, so using them with spironolactone could lead to dangerous hyperkalemia.
Got it. What about managing the portal hypertension itself?
For that, and specifically to prevent bleeding from those fragile varices, beta blockers like metoprolol or propranolol are commonly prescribed. They help lower the pressure in the portal system.
Okay. And other supportive meds?
Patients might need ferrous sulfate or folic acid. Anemia is common, particularly iron deficiency anemia, and chronic alcohol use can really deplete folate levels.
Antacids can help with general GI distress.
And in an acute situation like active variceal bleeding, you might see more potent meds like vasopressin or octreotide being used.
Okay, that covers the main meds. Now, let's talk diagnostic labs. It's not just about knowing the normal values, but what they tell you about the liver's function.
Exactly. So crucial indicators of liver function or damage include those enzymes, ALT, AST, and GGT. Elevated means cell damage.
And we mentioned protein earlier.
Right. Serum protein and serum albumin will typically be decreased, showing that the liver isn't synthesizing proteins properly.
Bilirubin will be increased, indicating problems with excretion.
Your clotting factors will be decreased.
Which means the prothrombin time, PT, measuring how long it takes blood to clot, will be prolonged. Longer time, higher risk of bleeding.
Yep. And serum ammonia levels are critical, especially for diagnosing or tracking hepatic encephalopathy. They can rise really quickly in severe liver failure.
And don't forget basic electrolyte levels, monitoring that sodium and potassium.
True. And interestingly, cholesterol might actually be elevated if the cirrhosis involves a biliary obstruction component.
Okay, labs give us the picture. Now, what are our priority interventions as nurses? What do we do first?
Think safety and comfort first. Always elevate the head of the bed. This helps reduce that respiratory distress caused by the ascites pushing upwards.
Makes breathing easier. Good. What about monitoring?
Non-negotiable. Daily weights and measuring abdominal girth. That girth measurement, especially tracking its change, is a key indicator for needing a paracentesis.
Okay. And activity?
You want to promote rest. This decreases the metabolic demands on that already struggling liver. And focus on improved nutrition. Malnutrition is so common here, especially with alcoholism.
And that itching, the pruritus.
Yes. Because of the bleeding risk from scratching, you should actually file the patient's nails short. Prevent skin breakdown.
Good practical tip. What about the ascites itself?
For significant ascites, a paracentesis might be done. That's where they physically remove the third-spaced fluid from the abdomen. It provides temporary relief.
But there's a risk, right?
Huge risk. Here's a critical point for your exam. Draining that fluid too quickly can cause hypovolemic shock. So it has to be done cautiously, slowly, and it often needs to be repeated.
Okay. Is there a more long-term fix for the pressure?
For managing portal hypertension more definitively, there's the TIPIAS procedure that stands for transjugular intrahepatic portosystemic shunt.
Sounds complex.
It is. They place a stent, basically, inside the liver, connecting the portal vein to one of the hepatic veins. This redirects blood flow, bypasses the scarred liver tissue somewhat, reduces portal pressure, and actually helps ammonia get into the systemic circulation to be excreted elsewhere.
Interesting. Okay, what about diet? This seems complex.
Dietary management is definitely nuanced. You'll restrict sodium, for sure, to help with the fluid retention. Sometimes fluids are restricted, too.
But what about protein? I feel like I learned to restrict it.
This is where things have really shifted, and it's a common point of confusion. Historically, yes, protein was restricted due to ammonia concerns, but now protein restriction is generally avoided. Why? because these patients are almost always already malnourished.
So restricting protein makes the malnutrition worse.
Exactly. Current recommendations are actually to provide adequate protein, usually around 1 to 1.5 grams per kilogram per day, to support their nutritional status and healing.
It's a really important update. Good to know.
Definitely. You'll also administer IV glucose. This helps minimize the body breaking down its own protein for energy. And vitamin replacements are key.
Which ones mainly?
Vitamins K, A, D, and E are often deficient because of malabsorption issues and the liver dysfunction itself. You'll often see banana bags used.
Ah, the yellow bags.
Yep, that combination of vitamins and electrolytes in an IV fluid bag. Great for rehydration and nutrient support. Diet-wise, encourage small, frequent, high-calorie, high-protein, low-fiber meals. This optimizes absorption and tolerance.
And if alcohol is the cause?
Then complete cessation of alcohol is absolutely critical, non-negotiable to prevent further liver damage.
Okay, and general patient education. What do they need to know?
Lots of safety points. Teach them no scratching use lotions, keep nails short to prevent skin damage and bleeding. Teach them no straining during bowel movements, as this increases pressure and the risk of variceal bleeding. Stool softeners might be needed.
Avoid certain meds.
Yes, definitely avoid NSAIDs or anticoagulants unless they are specifically prescribed and very carefully monitored by their provider due to that high bleeding risk.
And emphasize good skin and oral hygiene to prevent infections.
Absolutely. Skincare is paramount because the edema makes the skin fragile and prone to breakdown. So meticulous pressure prevention strategies are needed.
Use gentle soaps. Avoid harsh tapes.
Right. Use soothing lotions for irritation. And finally, always, always diligently monitor their mental status for any subtle or overt signs of worsening hepatic encephalopathy. Confusion, lethargy, changes in behavior.
Okay, comprehensive. Let's shift gears now to diabetes. We need to cover diagnostic testing and labs, those critical diabetic emergencies, hypoglycemia, DKA, HHS interventions for hypoglycemia, treatment for HHS and DKA, and those important sick day rules.
Right. Understanding the key differences and nuances between these emergencies, DKA and HHS especially, and knowing how to manage them quickly and effectively is so important for patient safety. High-yield stuff for the exam.
Definitely. So, starting with diagnostic testing and labs, your fasting glucose is a primary tool.
Normal is typically, 70 to 100 milli-GDL?
Generally, yes. And the key cutoffs are 101 to 125 milli-GDL indicates prediabetes. It's the warning zone. And 126 milli-DL or greater on 2 separate occasions is diagnostic for diabetes.
Got it. And the A1C?
The A1C, or glycosylated hemoglobin, gives you that bigger picture, right? It reflects average glucose control over the last 2-3 months.
And for most people with diabetes, the goal is usually lower than 7%.
Correct. You might also diagnose based on a random glucose level. If it's greater than 200 milli-GDL and the person has classic symptoms like increased thirst, frequent urination, unexplained weight loss that can diagnose type 1 diabetes especially.
Okay. And we also look at cholesterol, right? Cardiovascular risk.
We do. HDL, the good cholesterol, you want that greater than 35. It helps remove the bad cholesterol. And triglycerides, the main form of fat, should ideally be less than 150 milli-GDL.
Okay, labs covered. Now let's dive into those diabetic emergencies. This is where quick action saves lives.
First, hypoglycemia. This is when blood glucose levels just get too low. The brain needs glucose, so low levels are dangerous fast.
Simple, but critical. Then the big two. DKA, diabetic ketoacidosis.
This one is most associated with type 1 diabetes. Why? Because there's a severe, almost total lack of insulin.
Without insulin, the body can't get glucose into the cells for energy.
Right. So it panics and starts breaking down fat like crazy. This produces ketones, which are acidic byproducts.
So you get this dangerous triad: hyperglycemia, dehydration, electrolyte loss, and metabolic acidosis from those ketones.
And you see those classic signs. Small respirations, that deep, rapid breathing, trying to blow off CO2 to fight the acidosis.
And that distinct fruity breath odor from the acetone.
Exactly. Now contrast that with HHS, hyperosmolar hyperglycemic state.
This is more common in type 2 diabetics, often older adults. Here, there is some insulin floating around, just not enough to prevent severe hyperglycemia or let the cells use glucose properly.
And the key difference from DKA?
The absence of significant ketosis and acidosis. Because there's some insulin, it usually prevents that massive fat breakdown.
So what are the hallmarks of HHS?
Severe dehydration is a major one. Blood glucose levels are often extremely high, typically greater than the 600 milli-GDL.
When profound altered mental status, right? Confusion, lethargy, even coma. Plus hypotension and weakness from the dehydration. The neurological symptoms here can be really severe and take longer to resolve than in DKA.
Okay, knowing the difference is key. Now, how do we treat hypoglycemia? What are the interventions?
It really depends on whether the patient is conscious and able to swallow.
Right, so for the unconscious patient, you need rapid glucose replacement. That means glucagon intramuscularly, or if they're in the hospital, dextrose IV.
And if they are conscious,
Then you give fast-acting carbohydrates by mouth. Things like glucose tablets or gel, maybe 4 ounces of juice or regular soda, not diet soda.
good point. And then what? Just the fast carbs.
No, that's crucial. Once their blood sugar comes up, usually above 70 milli-UGDL, you need to follow up with a snack containing both carbs and protein.
Like what?
Peanut butter crackers, cheese and crackers, half a sandwich, something with staying power to prevent the glucose from crashing again.
And maybe a snack before bed for some people?
Yeah, especially if they're prone to overnight lows, a snack before bed can help prevent nocturnal hypoglycemia.
Okay, clear steps for lows. Now, for the big emergencies, DKA and HHS, what are the treatment interventions there?
Top priorities are similar initially. Rehydration therapy is absolutely number one. It's extremely important.
Especially in DKA, they can lose massive amounts of fluid, right? Up to 6.5 liters.
Easily. So fluid resuscitation is critical. Normal saline, 0.9% sodium chloride, is usually the first fluid you hang.
Then maybe switch based on labs?
Exactly. In HHS, you might adjust to other isotonic or even hypertonic solutions based on their sodium levels and overall osmolality. But start with normal saline generally.
Okay, fluids first, then insulin.
Yes. Once fluids are going and you know their potassium level, IV. Regular insulin is the first-line defense for bringing down those high glucose levels in both DKA and HHS. Regular insulin is the only one given IV.
And you mentioned potassium. Why is that so critical?
Electrolyte correction, particularly potassium, needs incredibly close monitoring. In DKA, potassium might initially be high because the acidosis pushes it out of the cells into the blood.
But
then, as you give insulin and correct the acidosis, the insulin drives potassium back into the cells. This can cause potassium levels to plummet rapidly, leading to dangerous hypokalemia.
so you have to watch the EKG.
Constantly. Assess EKG changes and cardiac rhythms very closely. You might need to add potassium to the IV fluids even if the initial level wasn't low.
Okay, fluids, insulin, potassium. What else?
Always ensure a patent airway. That's critical, especially in HHS where those neurologic symptoms can be so severe and last for days, maybe 3 to 5 days sometimes, to fully clear.
And finally, figure out why it happened.
Yes, you have to identify and address the precipitating factors. Was it missed insulin doses, an illness, or infection? Was this the first sign of previously undiagnosed diabetes? Treating the underlying cause is key to preventing recurrence.
Makes sense. Now let's talk sick day rules. This is crucial education for patients before they get sick.
Absolutely, and it can be counterintuitive. The number one rule, continue insulin as usual, or maybe even more, even if they're not eating much.
Why more?
Because illness itself, infection, fever increases metabolic stress and drives blood glucose levels up, regardless of food intake. The body releases stress hormones.
Okay, keep taking insulin. What else?
Drink liquids, lots of them. If they're vomiting or have diarrhea, even sugary drinks like regular Cokes or sports drinks can help prevent dehydration and provide some carbs.
And if they can't keep anything down?
They need to seek hospital care for IV fluids. Dehydration can happen fast.
And exercise.
Big safety point. Do not exercise if blood glucose is greater than 250 milli-GDL OR if ketones are present in the urine. Exercise can actually worsen hyperglycemia and ketoacidosis in those situations.
Good rules to know. Okay, moving to general education for diabetes management. Diet is foundational.
Yes, dietary management should focus on high-quality, nutrient-dense, high-fiber, minimally processed carbohydrates, not just avoiding sugar, but choosing better carbs.
And less sugary drinks, more water.
Definitely. Emphasize decreasing consumption of sugar-sweetened beverages and increasing water intake.
What about exercise recommendations?
The general goal is at least 150 minutes per week of moderate to vigorous intensity aerobic activity. Spread it out over at least 3 days a week with no more than 2 consecutive days off.
And resistance training too.
Yes, include 2 to 3 sessions per week of resistance exercise. This helps improve insulin sensitivity.
Okay, insulin therapy education must be thorough.
Absolutely. Patients need to understand their specific prescribed insulin and correct dosages, how to treat highs and lows, the importance of frequent monitoring, proper injection techniques, site rotation.
And if they use pumps or CGM?
Then education on pump usage is critical. For basal bolus therapy, the multiple daily injections they need to learn how to adjust their mealtime bolus insulin based on their anticipated carbohydrate intake. Carb counting becomes key.
Right. What about oral antidiabetics? We need to know the main ones.
Two big ones to know for exams. Metformin, which is a big one-eyed, it mainly works by inhibiting the liver from producing too much glucose.
And the crucial warning for metformin.
Metformin must be held before procedures involving intravenous contrast dye. There's a risk of lactic acidosis if kidney function is temporarily impaired by the contrast. That's a huge safety point.
Definitely. And the other big one.
Glipizide. It's a second-generation sulfonylurea. These work by stimulating the beta cells in the pancreas to secrete more insulin.
Okay. And monitoring at home.
Glucose monitoring is vital. Emphasize the importance of self-monitoring blood glucose levels at home as prescribed.
And increasingly continuous glucose monitors.
Right?
Like Dexcom. Or insulin pumps like Omnipod or T-Slams.
Yes, these technologies provide much more data and can really help fine-tune management. Education on using them correctly is essential.
Finally, complication prevention. This is the long game.
It really is. Teach patients the signs and symptoms of both hyper and hypoglycemia and how to treat them promptly.
Emphasize infection prevention, good hygiene, getting appropriate immunizations like flu and pneumonia shots.
And meticulous foot care measures to prevent ulcers and amputations. Daily inspection, proper footwear, seeing a podiatrist.
And just overall adherence, right?
Absolutely. Adherence to their entire treatment plan, meds, diet, exercise, monitoring, follow-up appointments is vital to prevent future emergencies and minimize those devastating long-term complications of diabetes.
Okay, great overview of diabetes. Let's tackle our final topic, the thyroid. We need to cover signs and symptoms of both hypo and hyperthyroidism, the emergency treatment of thyroid storm, the mixed coma priority, and key education points.
Right. The thyroid gland, though small, has this massive impact on metabolism throughout the entire body.
It really does.
Yeah.
It regulates the metabolic rate of pretty much every single cell. So when it malfunctions, the effects are widespread and can be dramatically opposite, which makes understanding the differences critical for exams.
Exactly. Let's start with hyperthyroidism, often caused by Graves' disease. The easiest way I find to think about it is that everything is sped up.
Okay, sped up. So what does that look like?
Patients are generally hot and agitated. You'll see an excessive increase in heart rate tachycardia and an increased body temperature.
Nervous system on overdrive.
Totally. Leads to anxiety, irritability, insomnia, muscle weakness, trembling hands, sweating a lot, and a profound heat intolerance. They just can't stand being warm.
Metabolism is high, so.
Yeah. Weight loss without trying, even though they might be eating more. And that sped up GI tract leads to frequent bowel movements, sometimes diarrhea.
And physical signs.
A very common one is goiter, which is just an enlarged thyroid gland you might see or feel in the neck. It's working overtime.
And the eyes.
Ah, yes, exophthalmos. That's the characteristic bulging eyes. It can also cause a gritty feeling, watery eyes, maybe blurry vision. It's due to inflammation and swelling in the tissues behind the eyes.
And that increased metabolism affects the heart, too.
Yes, the increased metabolic rate means increased oxygen consumption by all tissues. This leads to restlessness, irritability, palpitations. If it's severe and prolonged, the heart can't keep up. Cardiac output can decrease, potentially leading to heart failure.
Okay, that's hyper, fast, and hot. Now, hypothyroidism, like in Hashimoto's disease, what's the key idea here?
Here you think everything is slowed down, low and slow. It's the complete opposite picture.
So instead of hot,
They're typically cold. They gain weight even without eating more and experience profound fatigue and lethargy. Just no energy.
and vital signs reflect this slowdown.
Absolutely. You'll see bradycardia, a slow heart rate, hypothermia, low body temperature, and often decreased blood pressure.
Other physical signs.
They might have an expressionless or sort of mask-like face. Their skin can be dry, flaky, and elastic, often a puffy face, drooping eyelids. Hair loss might be patchy, and nails can become thick and brittle.
And GI system. Opposite of hyper.
Exactly. They commonly suffer from severe constipation.
Okay. Any critical safety issues with hypo?
Yes, definitely. Because everything is slowed down, including respiratory drive, they often have inadequate ventilation and can develop sleep apnea.
And medication sensitivity.
Extremely important. They are very sensitive to sedatives, opioids, and anesthetic agents. Their slow metabolism means these drugs hang around longer and have much more potent, potentially dangerous effects, especially respiratory depression.
And heart issues here too, different kind.
Yes. Myocardial ischemia due to underlying coronary artery disease is a concern. The slowed metabolism means less oxygen is being delivered efficiently to the heart muscle, which can exacerbate existing artery disease and potentially lead to heart failure over time.
Okay, clear contrast between the two. Now, the emergencies. Let's start with hyperthyroidism's emergency, thyroid storm.
This is a true life-threatening condition. It's like hyperthyroidism on steroids, an extreme exacerbation of all those symptoms.
What are the hallmarks?
Exceptionally high fevers, dangerous dysrhythmias, severe neurological impairment, think delirium, seizures, coma, and potentially heart failure leading to circulatory collapse. It's bad.
So what's the priority treatment?
Immediate symptom control is key. Control with beta blockers like atenolol is crucial to slow down that dangerously high heart rate.
Monitoring.
You have to monitor vital signs frequently, constantly, and anticipate the need for continuous cardiac monitoring because those dysrhythmias are a major risk. Prioritize treating the impaired heart function.
And the fever.
You need to actively control body regulation and temperature. Cooling blankets, acetaminophen, get that fever down.
Environmental controls, too.
Yes, absolutely. Avoid extreme temperatures in the room. Keep the patient's room cool and quiet. Reduce stimulation as much as possible.
Other meds they might use.
Besides beta blockers, they'll use thyroid hormone antagonists like methimazole or propylthyroxine, PTU, to block hormone production. Maybe calcium channel blockers if beta blockers are contraindicated. Iodide solutions can block the release of stored hormone, and anticoagulants might be needed if they develop arrhythmias like atrial fibrillation.
Okay, intense. Now, the hypothyroidism emergency, myxedema coma, what's the priority here?
This is also life-threatening. The patient becomes extremely hypothermic and usually unconscious. Everything slows down to a critical level.
So what's the absolute #1 priority?
Maintaining airway patency with ventilatory support is the highest priority. Their respirations are significantly depressed due to the extreme metabolic slowdown. They can easily lose their airway. Intubation and mechanical ventilation are often necessary.
And that sensitivity to drugs we mentioned.
Critically important here. Be acutely aware of their extreme sensitivity to sedatives, opioids, and anesthetic agents. Even standard doses can cause profound respiratory depression or prolonged coma. Use them with extreme caution, if at all.
Other care points.
You need to provide adequate rest periods to conserve what little energy they have and actively keep the patient warm using warming blankets to counteract the severe hypothermia.
Can this develop gradually? What are early signs?
Yes, it can sometimes be precipitated by an illness or stopping thyroid meds, but early warning signs might include worsening depression, a noticeable decrease in cognition, or sometimes patients relying on supplements instead of prescribed thyroid hormone.
Okay, emergencies covered. Let's wrap up with education, both general and medication-specific.
A key message, especially for hypothyroidism, is the importance of taking medications as prescribed. Treatment, particularly with levothyroxine or Synthroid, is almost always lifelong replacement therapy.
And levothyroxine has specific instructions, right?
Yes, very specific and important for exams. It must be given on an empty stomach at least 30 to 60 minutes before breakfast. Food significantly interferes with its absorption.
And switching brands.
Advise patients not to switch brands without talking to their doctor. Even small differences in formulation between brands can affect absorption and thyroid levels. Consistency is key.
Other lifestyle advice for hypothyroidism.
Educate them on avoiding the cold and dressing warmly, and because of the constipation.
They should institute a bowel training program, increase fluids, and eat high-fiber, low-sodium, low-calorie foods. Low calorie because of the slow metabolism and weight gain tendency.
Right. Now, for hyperthyroidism, diet advice is the opposite.
Pretty much. Encourage small, frequent, high-calorie, high-protein, low-fiber meals to try and meet that incredibly high metabolic demand and prevent further weight loss.
And critical reporting.
Absolutely. Educate all thyroid patients, but especially hypothyroid patients, to immediately notify their practitioner if they experience any signs or symptoms suggestive of myxedema coma or even just significantly worsening hypothyroidism. Early intervention is key.
And a general safety point for procedures.
Yes. Patients need to know to inform any healthcare provider about their thyroid disease before procedures, especially those involving iodine contrast, as it can significantly impact thyroid function. Finally, what about definitive treatment for Graves' disease?
Radioactive iodine therapy is a very common treatment, especially for females who are past reproductive age or aren't planning more children. It basically destroys the overactive thyroid tissue. Surgery to remove the thyroid is another option.
Okay, we have really covered a lot of ground today,
You.
from the complexities of the liver and cirrhosis
To that delicate minute-by-minute balance of blood sugar and diabetes.
and the huge systemic impact of thyroid hormones.
Yeah, and if we sort of step back and connect this to the bigger picture, it just highlights again how profoundly interconnected all our body systems truly are, doesn't it?
It really does. And how a deep understanding of these cellular regulation processes, not just, memorizing facts, is absolutely foundational to providing safe, comprehensive patient care.
Totally agree. So as you prepare for your exam, try to think beyond just the lists. Really try to understand the underlying why behind each symptom, each intervention.
Ask yourself, how does this connect? Why does this happen?
Yeah. Maybe a final thought to ponder as you review. What stands out to you as the most surprising link you noticed today, or perhaps the most counterintuitive piece of information, maybe between these different systems we discussed? Thinking about those connections can really solidify your understanding.